Welcome, deep divers. So thrilled to have you with us today. We are embarking on another deep dive, really getting into the depths of understanding something pretty fundamental. Today, it's fever, something every single one of us has dealt with, right? Seems simple, maybe, but it's actually incredibly complex and often, profoundly misunderstood. That feeling when you're warm, a bit achy, and you think, am I actually sick here? It's just such a common scenario. And, fever is easily one of the top reasons people see a doctor anywhere in the world. It's this universal signal, an alarm bell saying something's up in the body. But here's the thing we often miss, I think. It's not just a symptom. It's more like a diagnostic puzzle piece, a really critical bit of info waiting for us to decode it. And our mission today really is to explore how a structured approach, like being a detective about it, specifically looking at the history of the fever, can unlock crucial clues long before any lab tests even get ordered. Like, what if the key to figuring out what's wrong was hidden right there in the details you remember about your fever before any blood draws or scans? We're going to show you how to read those signs.
That's precisely it. And in, clinical practice, day to day, a focused, systematic way of asking about fever history, it can just dramatically narrow things down so efficiently. It's really an incredibly powerful method. Transforms a vague complaint into a pretty precise pointer, guiding us towards what might actually be going on underneath. And understanding these nuances, it's not just for clinicians, it's a shortcut for anyone to be better informed, to understand your own body, empower yourself in those healthcare chats. So yeah, throughout this deep dive, we're going to move through these distinct, critical areas of questioning, step by step, equipping you with the tools to sort of master this approach. Think of us as your guides on this investigative journey.
All right, investigation officially launched. And like any good detective, we got to start at the beginning. The very first piece of evidence, and it's one that maybe surprisingly gets overlooked a lot. Confirming if there actually was a fever sounds almost too basic, doesn't it? But how many times do we say, oh, I feel hot, must be a fever, without, actually grabbing a thermometer?
Oh, constantly. It happens all the time.
There's a real difference between just feeling warm and having that objective number.
Exactly. A huge physiological difference.
So the absolute first question, the foundation for everything else is, did you actually measure the fever, or did you just feel hot?
It's such a fundamental question, but yeah, it's important. You're right. It can't be overstated. The subjective feeling of warmth.
Yeah.
It could be anything, really. You worked out hard, you're in a hot room, maybe even feeling anxious or excited, makes you feel flushed. But clinically, for us, fever has a very specific objective definition based on measurement. For most adults, normal is around 98.6 Fahrenheit, 37 Celsius. And here's something people often don't realize. Your temp can nudge up a bit in the evening, maybe to 99F. Still totally normal. Part of the body's natural rhythm.
Right, the diurnal thing.
Exactly. But once that measurement hits 100.4 Fahrenheit, or 38 Celsius, that's when we officially say, okay, that's a fever. Clinically speaking, that's our line in the sand. And why does this distinction matter so much? Well, for both the person feeling sick and the clinician, if you mistake feeling hot for a real fever, like you said, you might worry unnecessarily.
Yeah, maybe run to the doctor when you don't need to.
Or take medicine you don't need. Or the flip side, and maybe this is more concerning, dismissing a real measured fever because you think, oh, I just feel a bit warm. That could delay getting help for something serious.
Okay.
Physiologically, a true fever isn't just heat. It's your body's internal thermostat, the set point in your brain, specifically the hypothalamus, being actively turned up.
Like adjusting the heating in your house.
Precisely. It's a regulated response to these things called pyrogens, chemicals released by your immune system when it detects, say, bacteria or viruses.
Yeah.
The body then works to reach that higher temperature. That's why you sometimes shiver when you have a fever, even though you're hot. Your body's trying to generate more heat. It's a complex, purposeful immune response. Whereas just feeling hot from running, your thermostat's normal, your body's just trying to get rid of excess heat.
Okay, that distinction is really clear. Thermostat up versus just shedding heat.
Exactly. So once we establish, okay, yes, a measurement was taken, the follow-up questions become absolutely crucial for assessing severity, understanding the fever's behavior, getting those details. We need to know, what was the maximum temperature recorded?
Right, how high did it actually go?
Yeah, helps gauge the intensity. A steady 103 is different from a fleeting 100.5, Then what time of day did it happen?
Because of that natural rhythm again.
Precisely. Helps us interpret the reading correctly. Is it high even for the morning or just hitting the usual evening peak? And finally, this is a big one. Were any medications taken that might influence the reading?
Like Tylenol or Advil, ibuprofen, acetaminophen.
Exactly. Antipyretics.
Uh.
They're designed to lower fever. If someone took one before measuring, it could totally mask the true peak.
Giving a false impression.
Right. A misleadingly low reading. So you see how even this initial data point, getting the number right, with context, it immediately starts to shape the diagnostic picture. Is it persistent? High. Or fluctuating? Low grade. It's the first big clue.
That's incredibly insightful. So it's not just if you have a fever, but how high, when, and under what conditions, like medication use, which brings up a really practical question then. You mentioned measurement. How do you measure it accurately? There seem to be so many options now. Oral, under the arm, ear, forehead scanners. Doesn't matter which one you use for this detective work. Is one better?
You're absolutely right. There are several common ways, and each has its own, let's say, pros and cons regarding accuracy and use, like different tools for collecting evidence. The most common, generally reliable for adults and older kids, is oral. Digital thermometer under the tongue.
Okay, standard method.
Pretty much. Then there's axillary under the armpit. This one's generally seen as less accurate. It's measuring surface temp, not core body temp. It typically reads about maybe 0.5 degree Celsius or 1 degree Fahrenheit, lower than oral or rectal.
So less reliable.
Less precise for diagnosis, yeah. Often used for convenience, maybe with kids who can't hold an oral thermometer still, but you have to take the reading with a grain of salt, diagnostically speaking. Now, for infants and very young children, rectal temperature is often considered the gold standard.
Really? Why is that?
Because it gives a true core body temperature reading. It's less influenced by outside factors. Might be less convenient, sure, but for little ones where precision is really key, it's the most accurate. And then you've got the newer ones, tympanic, in the ear, and temporal artery across the forehead.
Yeah, those seem popular. Very quick.
They are. Super fast, non-invasive, great for screening lots of people quickly, but their accuracy can sometimes be a bit iffy. Depends on user technique. Well, with the ear ones, earwax buildup can interfere. With the forehead ones, sweat can throw off the reading. So while they're convenient, you just need to be aware of those potential limitations. Choosing the right site, or at least knowing which site was used, helps ensure we're working with reliable data. And reliable data, well, that's the bedrock for everything else we figure out. Can't solve the puzzle if the first piece is fuzzy, right?
That makes perfect sense. Garbage in, garbage out, as they say. Okay, so step 1, confirm the fever, measure it accurately, note the peak, the time, any meds. Got it. Now, we shift gears from if there's a fever to how it behaves. And this is where, for me, it gets really fascinating. Because fever isn't just a flat number, is it? It can follow these distinct patterns.
Yeah.
Like a signature for the illness.
Exactly. A modus operandi.
Yeah. Each pattern is like a potential clue. It's like listening to the body's rhythm, sometimes steady, sometimes erratic, sometimes repeating a very specific beat.
Yeah.
That tells you something profound about what's causing it.
Absolutely. The pattern is an incredibly powerful diagnostic tool. It can significantly narrow down the possibilities of differential diagnoses, helps us finger the suspect much faster. Let's break down the 4 main patterns we look for. Each tells a different story. First up, we have continuous fever. In this pattern, the temperature stays elevated. It doesn't really vary much throughout the day. Maybe it fluctuates a tiny bit, like 1 degree Celsius, a couple degrees Fahrenheit. But the key thing is, it never returns to a normal baseline. Stays high.
Okay, just constantly up.
Right. A classic example where you see this, where the body's inflammation is just consistently high, is typhoid fever. This lack of dipping back to normal suggests something persistent, maybe systemic, that the body's struggling with constantly. The battle just doesn't let up. Okay, next is intermittent fever. This one's quite different. It's characterized by spikes. The fever shoots up significantly, but then it comes all the way back down to normal or near normal in between those spikes.
So up and down, but hitting normal in between.
Exactly. High temp, then baseline, then high again. Also happens repeatedly. This pattern is often linked with things like malaria or sometimes sepsis. Those returns to normal might suggest periods where the immune system gets a temporary edge, or like in malaria, which we'll get into, it actually mirrors the bug's life cycle. The timing is the giveaway. Then there's remittent fever. Now, this one can be a bit tricky because it also fluctuates.
Okay, how is it different from intermittent then?
The key difference is, while it fluctuates, it never goes back down to the normal baseline temperature.
Ah, so it goes up and down, but always stays above normal.
Precisely. It varies, maybe by more than 1 degree Celsius during the day, but it never quite hits that normal mark. Infective endocarditis, that's a serious heart valve infection, often presents with this kind of remittent pattern. It implies this ongoing, persistent infection. The body's constantly fighting, but never quite clearing things enough for the temp to normalize fully. A constant, maybe low grade, but losing battle. And finally, number 4, relaxing fever. This one's distinct because you get these episodes of fever, maybe lasting several days, separated by periods where there's no fever at all, days, sometimes even weeks of feeling completely fine in between.
Wow, so it comes back after disappearing completely.
Yes, exactly. Examples here include brucellosis, often from unpasteurized dairy or animals, or borreliosis, like Lyme disease relatives. This pattern is a real diagnostic challenge sometimes because the person feels better for a while, might delay seeking help, or the connection isn't made. Recognizing this long-term on-again, off-again pattern is absolutely crucial for nailing those persistent, tricky diagnoses. Now, within that intermittent category, the source material highlights something incredibly cool and highly diagnostic: the malarial fever patterns.
Ah, yes, you mentioned them.
They're so powerful because the timing, the precise timing, directly reflects the parasite's life cycle inside our red blood cells. It's like the body's rhythm is perfectly synchronized with the pathogen's rhythm, a direct mirror. For instance, you have tertian fever. The fever spikes occur, like clockwork, every 48 hours, every 2 days.
Every 48 hours, exactly.
Pretty much. That specific timing screams Plasmodium vivax or Plasmodium oval malaria. Imagine every other day, boom, the fever hits, often with chills, then sweats, as those parasites burst out of the red cells. Then there's quartan fever. Here, the spikes happen precisely every 72 hours, every 3 days.
Okay.
This pattern points directly to Plasmodium malaria. Again, the regularity is the key. You could almost set your watch by it. And lastly, quotidian fever. This means daily spikes, every 24 hours or so. This pattern is often associated with Plasmodium falciparum, and that's important because falciparum malaria is the most severe, the most dangerous, potentially fatal form.
Wow, so the daily pattern flag's the most dangerous type.
Often, yes. And why are these timings so incredibly specific, so diagnostic? It's because they are synchronized with that moment when infected red blood cells rupture, releasing a new generation of parasites into the bloodstream. That massive release triggers the big immune response, the fever spike. This cycle of destruction and release creates that predictable rhythm.
That's amazing. It's like the parasite has its own schedule.
It does. And knowing these patterns, it can guide immediate, potentially life-saving treatment, even before you get lab confirmation. It gives clinicians an invaluable head start, like a detective knowing the exact timing of a serial crime.
That's truly incredible. A real aha moment for me, too. So just asking that seemingly simple question, did the fever come at the same time each day, or every other day, or every third day? It yields such powerful, almost immediate insights. I can just imagine the clinician's mind racing when they hear, oh yeah, it's like clockwork every 48 hours.
Absolutely. Click.
Instantly narrows the field from this huge ocean of possibilities down to a very specific list of suspects, like being handed a map and compass in a thick fog. Okay, let's unpack this even more. We've confirmed the fever, we've analyzed its pattern, its rhythm. Now, like a detective meticulously examining a crime scene, once we know the fever's pattern, what other clues are we looking for? What else is the body telling us? Because fever rarely travels alone, right? It usually has an entourage, other signs, other symptoms.
Exactly, fellow travelers.
Yeah, these are the body's way of whispering, or maybe sometimes shouting, hey, look over here, this is where the problem is, tells us which system is under attack.
Precisely. These associated symptoms are vital pieces of the puzzle, like finding specific fingerprints at the scene. And we approach this systematically. We do a sort of system-by-system review of the body, because where the symptoms show up tells us a lot about which organ system is hit, pointing us towards the source of the trouble.
Yeah.
Let's start with the respiratory system, lungs and airways. If someone with a fever also reports, say, a persistent cough, or they're coughing up sputum that's mucus, phlegm from the lungs, or they feel short of breath.
Difficulty breathing.
Yeah. Then we immediately start thinking about lungs. Pneumonia, maybe,
right.
An infection in the lung tissue itself, or maybe tuberculosis, TB, and the details matter. Is the cough dry and hacking, or wet and productive? What color is the sputum? Clear, yellow, green, maybe even bloody. Yeah, but those details are crucial clues. They guide us further. Okay, moving down to the gastrointestinal GI system. Stomach, intestines. Here, symptoms like diarrhea, often with abdominal pain, maybe vomiting. If those come along with the fever, it might suggest something like enteric fever, which includes typhoid, or maybe viral hepatitis like Hep A or E, or even amoebiasis, a parasitic gut infection.
So gut problems plus fever point that way.
Generally, yes. Yeah. And again, the character matters. Is the diarrhea watery, bloody? How often? Is the person getting dehydrated? All vital details. Then the genitourinary. GU system. Urinary tract, kidneys. We specifically ask about dysuria, that's painful urination, stinging or burning, or flank pain, pain in the side of the back, kind of where the kidneys sit.
Right.
If you have those symptoms plus fever, it strongly suggests a urinary tract infection, a UTI, or potentially something more serious like pyelonephritis, which is a kidney infection. Needs prompt attention. Next, the central nervous system, CNS. Brain and spinal cord. This is critical territory. Symptoms like a severe headache, especially one that's different or worse than usual for that person, or neck stiffness, specifically pain or difficulty trying to touch your chin to your chest.
The classic meningitis sign.
Exactly. These are major red flags when paired with fever. They could indicate very serious things like meningitis, inflammation of the brain's coverings, or encephalitis, inflammation of the brain itself. These symptoms always warrant urgent medical evaluation. Potential for rapid decline, severe damage. You don't wait on these, they're screaming alarms. The skin can also offer up really important clues. Seeing a rash, or maybe ulcers alongside a fever, could make us think about diseases like dengue, or chikungunya, or leptospirosis. And the type of rash is key. Is it maculopapular flat red spots with some raised bumps? Is it vesicular little fluid-filled blisters? Or crucially, is it petechial? Those tiny pinpoint red or purple dots that don't disappear when you press on them.
Right, you mentioned petechial rash in the red flag section later too. Very serious sign.
Extremely serious. We'll definitely come back to that. But yeah, the different rash types point towards different potential causes. Visual evidence. And finally, the musculoskeletal, MSK system. Muscles and joints. Myalgias, that's just severe muscle aches and joint pain, are super common with lots of viral fevers. Gives you that horrible flu-like feeling.
Yeah, feeling like you've been hit by a truck.
Exactly that feeling.
Yeah.
But they can be particularly severe, really prominent in diseases like dengue and chikungunya. Dengue is even nicknamed breakbone fever sometimes because the muscle and joint pain can be so intense, so debilitating. And here's a specific symptom spotlight, a great example of a golden nugget clue. Retroorbital pain.
Pain behind the eyes.
Yes, specifically pain behind the eyes, often described as a deep, aching pressure back there. It sounds kind of niche, right? But it is strongly suggestive of dengue fever.
Wow. Why is that one so specific?
It's just quite characteristic of dengue. Not many other common things cause that specific symptom so reliably. So especially if you're in an area where dengue is common, hearing about fever and retroorbital pain immediately puts dengue high on the list, even before tests come back. It's like finding a unique calling card left by the culprit. So when we ask those questions like any chills, body aches, rash, urinary symptoms, headache, we're not just going through a checklist. We are systematically trying to build a symptom fingerprint for what's going on. And it's often the combination of symptoms, that unique cluster, that's more diagnostic than any single one alone.
Putting all the pieces together.
Exactly. It helps us differentiate between diseases that might all cause fever, but have different accompanying clues. Creates a much clearer picture of our suspect. And knowing this, being able to clearly articulate these symptoms, it really empowers you, the listener. If you can tell your provider, yes, I have a fever, it started 2 days ago, peaks in the evening, and I have this bad headache and pain behind my eyes, that's incredibly helpful.
Yeah, it speeds everything up.
Dramatically. Leads to faster diagnosis, more timely, effective treatment. You're providing crucial evidence for the investigation.
That's such an important takeaway. Knowing what to look for in yourself and how to describe it really makes a difference. Okay, so we've covered the fever itself, confirmation, measurement, pattern. And we've covered the associated symptoms, the body's internal clues. But now this is where the investigation broadens out. It gets really interesting, I think. Beyond the individual's body to their environment, their recent experiences, the story isn't just in your body, is it? It's also in your world.
Oh, absolutely. Context is everything.
These external factors are incredibly powerful diagnostic pieces, like a geographical or lifestyle fingerprint pointing to the culprit.
Exactly. This is where we dive into the epidemiological history. Epihistory for short. It's all about your interactions with the world around you. How might those have influenced your health, exposed you to something? It's like examining the suspect's movements, their associates, where they've been hanging out. First, and often most critical, is travel history. We ask, where have you been recently? Where did you just come back from?
Because different places have different bugs. Yeah.
Precisely.
Yeah.
Specific regions, countries, even local areas like, say, SWAT or DARE mentioned in the source, are known hotspots for certain diseases. Malaria, leishmaniasis, dengue. Depends where you go. We also think about incubation periods, how long it takes symptoms to show up after you're exposed. Does the timing fit with your travel dates?
So if you got sick the day after you got back, it might be something different than if it took 2 weeks?
Exactly. That timeline is key. Just knowing you returned from a malaria endemic area can dramatically narrow the possibilities, from thousands of diseases down to maybe just a handful. It's like knowing the neighborhood where the crime likely happened. Next up, occupation. What do you do for work? Because some jobs inherently carry higher risks for specific exposures. Farmers, vets, slaughterhouse workers, they might have more contact with animals, increasing risk for things like leptospirosis from contaminated soil or water, or brucellosis from infected animals.
It makes sense. Different environments, different risks.
Totally. Healthcare workers face risks like drug-resistant bacteria. Construction workers may be tetanus if unvaccinated. Understanding your daily work environment gives us clues about potential specific exposures. Then there's animal exposure. Been around animals, domestic pets, livestock, wildlife, even pests like rats or ticks.
Ticks are a big one lately, seems like.
Definitely. Tick bites raise concerns for Lyme disease, other tick-borne illnesses. But it's not just bites or scratches, which make you think of rabies or bacterial infections. It's also indirect contact. Like, did you drink unpasteurized milk? That's a classic row for brucellosis.
Yeah.
Handle raw meat. Even just living near areas with rodents can matter for things like hantavirus or leptospirosis. Contact with animal waste. Mosquito exposure is huge too. West Nile, Zika, chikungunya.
So, understanding all those potential vectors.
Exactly. Your water source is another key detail, especially if there are GI symptoms involved. Where do you get your drinking water? Municipal supply. Private well. Did you drink from a stream while hiking?
Stuff you might not even think about.
Right. But contaminated water is a major source of things like typhoid, hepatitis A, parasites like Giardia or Crypto. Knowing about your access to safe water and sanitation helps assess risk for a lot of these gut infections. Did your well flood recently? Did you eat street food with questionable water? Details matter. And finally, vaccination status. Are you up to date? Especially for things relevant to where you live or travel. Typhoid vaccine, hepatitis A, B measles, tetanus.
Because that helps rule things out.
Absolutely. If you're fully vaccinated against, say, hepatitis A, and you have jaundice and fever after travel, maybe we look harder for other causes first. It helps focus the investigation, makes certain diseases much less likely suspects. And just to illustrate how this works, imagine that scenario. Someone comes in, fever, terrible body aches. You ask how I travel. Oh yeah, I just got back last week from volunteering in rural West Africa.
Okay, malaria bells start ringing.
Immediately. Especially if their fever pattern fits, like every 48 hours, you'd likely do an urgent malaria test. Could save their life. Or, another example, a dairy farmer comes in, fluctuating fever, joint pain, mentions drinking raw milk from his own cows.
Brucellosis pops into your head.
Right away. It's connecting the dots, the who and what of the fever with the where and how of potential exposure. These aren't just random questions, they're direct diagnostic pathways.
It's truly amazing how much our environment and experiences tell the story. It really drives home that fever isn't just what's happening inside you, it's also about what you've interacted with, where you've been. So those crucial questions. Traveled recently. What's your job? Any animal contact, sick contacts, funny water. They add these powerful lenses to our diagnostic magnifying glass. Okay, so now let's bring the focus back inward again to the individual's personal health story. Because medications you're currently taking or illnesses you've had before, they can really change the game, right? Change how fever presents, what it means.
Oh, massively.
It's not just about the new thing. It's the whole context, the whole health narrative of our subject.
Absolutely. This part, looking at medication and past medical history, is incredibly important. It accounts for that individual variability. Everyone's different. It's about understanding the unique circumstances of this specific case. First, something people might find surprising. Sometimes, drugs can actually cause fever.
The medicine itself causes the fever, not an infection.
Correct. We call them drug-induced fevers. It's an adverse reaction to the medication. Classic examples include certain anticonvulsants drugs for seizures or nerve pain, and some antibiotics, like sulfonides, are well known for this.
How does that happen?
Often it's a hypersensitivity reaction. The immune system kind of freaks out and mistakenly reacts to the drug like it's an invader, triggering inflammation and fever. So if someone starts a new med and then spikes a fever a few days or a week later, that drug jumps way up the suspect list. Often, stopping the drug makes the fever go away. But equally important, sometimes even more critical for diagnosis, is looking for drugs or conditions that can mask fever.
Mask it, meaning hide it.
Exactly. Suppress it, blunt the response, make it seem less severe than it is, or even absent altogether. This is vital for interpretation. For example, steroid use. Things like prednisone, often used for autoimmune diseases, asthma, bad allergies. They're powerful anti-inflammatories. They can significantly dampen the body's ability to mount that inflammatory response, including fever.
So you could have a serious infection, but not much fever.
Precisely. Same goes for immunosuppression from other causes. People with HIV, active cancer undergoing chemo, organ transplant recipients on anti-rejection drugs, their immune systems are weakened. They're a much higher risk for serious infections, but their weakened system might not be able to produce a high fever.
Wow, that's scary.
It is. What might be a screaming 104 fever in a healthy person could be a mild 100.5, or even no fever in someone immunocompromised, even with a life-threatening infection brewing. It makes our job harder and highlights why knowing this history is absolutely paramount. A mild fever in that context could be incredibly serious. The alarm system is faulty, even if the danger is high. Similarly, a history of underlying conditions like, say, previous tuberculosis, TB, or known HIV infection, or a history of malignancy, these profoundly change the list of possibilities when that person develops a fever.
How so?
Well, a fever in someone with a history of TB might mean the TB has come back or spread. In someone with HIV, a fever could be the first sign of an opportunistic infection, one that wouldn't normally bother a healthy immune system. And in cancer patients, fever can sometimes be caused directly by the cancer itself. We call that perineoplastic fever. Or it could be an infection they're prone to because their immunity is down from the cancer or the treatment, like chemotherapy. A lymphoma patient with fever could be either the disease progressing or a nasty mast infection. Big difference. This really underscores why getting a thorough medical history is never just, checking boxes, every medication, every past illness, every underlying condition. It changes the entire landscape for interpreting new symptoms like fever, provides that critical context for the whole investigation.
That really drives home the complexity, the interconnectedness of our health. It's the whole story, not just the current chapter. So those key questions for you to remember and tell your provider. Are you taking any regular meds? Even over-the-counter stuff, supplements, recently hospitalized, any known health conditions? Who? Seemingly simple questions, but wow, they hold immense diagnostic weight when you layer them onto everything else, the measurements, patterns, symptoms, the epi-story. Okay, now we shift to what is maybe the most critical piece of this whole deep dive, and really any medical investigation, recognizing the signs that scream danger, immediate threat.
The flags.
Exactly. What does all this detective work boil down to in an emergency? It means knowing when to worry, and crucially, when you need to act fast. These are the urgent signals, the body's DEFCON 1 alarms telling us it's in serious distress and needs help, like now?
These are indeed the absolute critical red flags. Symptoms that demand immediate medical attention because they signal severe complications, potentially life-threatening causes. Knowing these can literally be the difference between life and death. Empowering you with this knowledge is just paramount. First, confusion or altered mental status. This is a huge one. If someone with a fever becomes disoriented, unusually drowsy, hard to wake up, starts acting strangely, isn't making sense.
Not themselves at all.
Right. It suggests the brain is involved. Could be a severe infection like meningitis or encephalitis directly affecting the CNS, or it could be severe systemic toxicity. The infection or inflammation is so bad it's affecting brain function indirectly. Requires urgent evaluation, usually in an ER. Next, a petechial rash. We mentioned this earlier. Those tiny pinpoint red or purple spots, and the absolute key is they don't blanch.
Meaning they don't turn white when you press on them.
Exactly. Press a glass against them, they stay red or purple. It's like tiny bruises under the skin, caused by bleeding from damaged capillaries. Seeing a petechial rash with fever is a critical warning sign for things like meningococemia, a super fast, dangerous bacterial infection, or severe dengue hemorrhagic fever. Indicates serious trouble with blood vessels or clotting. Neck stiffness, another classic we touched on. Significant difficulty or pain trying to bend the neck forward, touch chin to chest, or excruciating pain turning the head with fever. Very strong indicator of meningitis, inflammation around the brain and spinal cord.
Medical emergency.
Absolute medical emergency. Needs immediate evaluation, likely a lumbar puncture, to prevent devastating neurological damage, deafness, or worse, seizures happening with a fever. So extremely serious, particularly in older children or adults.
I thought kids sometimes had febrile seizures that were okay.
Young children, yes, can have benign febrile seizures with high fevers. But a seizure in anyone else with a fever, that's a different story. It could signal very serious things like cerebral malaria, encephalitis, major brain involvement, demands immediate attention, high risk of damage, any unusual or unexplained bleeding. like bleeding gums when brushing teeth, nosebleeds that just won't stop easily, coughing up blood, or finding lots of bruises without knowing how you got them.
Especially with a fever happening, too.
Yes, that combination. You can signal a severe problem with blood clotting, or conditions like dengue hemorrhagic fever, where capillaries leak dangerously. Suggests a major systemic breakdown. And finally, hypotension, or shock. Dangerously low blood pressure. And signs that organs aren't getting enough blood flow, feeling dizzy, lightheaded, heart racing, skin cold and clammy. Confusion again, maybe not making much urine.
The body is starting to shut down.
Essentially, yes. It's a hallmark of severe sepsis or septic shock. The body's response to infection goes haywire and starts damaging its own organs. This is a life-threatening emergency requiring urgent resuscitation, often in an ICU setting. The reason these are all red flags, unequivocally, is because they signal a shift. From just having a fever to actual organ dysfunction, widespread overwhelming infection, or life-threatening complications. They tell us the body's coping mechanisms are failing. Rapid action is needed to prevent irreversible harm or death. So while this whole deep dive is about empowering your understanding, empowering you to talk to your doctor, it is absolutely crucial to stress. These specific red flag symptoms are a clear, undeniable call for immediate medical help.
Don't wait, don't second guess.
Don't delay. Don't try to self-diagnose these. It's about empowering you to know when to hit the panic button and get professional help urgently, because minutes really can matter in these situations.
Those are truly vital signals. So important for everyone listening to take that urgency to heart. Being alert to those red flags, whether it's for yourself or someone you care about, it could literally save a life. It's the ultimate so what from all this detective work. And with that incredibly important note, we bring this deep dive, our investigation into decoding the language of fever, to a close. We've journeyed quite a way, haven't we? From just confirming if there is a fever, to understanding its intricate patterns, like its unique rhythm or fingerprint, deciphering the body's whispers through all those associated symptoms, exploring the crucial influences from your environment, your travels, your history, and finally, identifying those critical red flag symptoms that scream for immediate action. Our real hope, after all this, is that you now see fever differently, not just as some miserable symptom you want to get rid of, but as a sophisticated diagnostic clue. A really vital piece of evidence. The structured approach asking these questions, it truly unlocks profound diagnostic power. It helps paint a much clearer picture, often way before the tests even come back. Turns that vague feeling into concrete, actionable intelligence. So thank you for joining us on this, I think, incredibly insightful journey. Thank you for empowering yourselves with this knowledge.
Yeah, it's been a real pleasure to share this perspective. What we've walked through today really highlights the profound efficiency and power hidden in just asking the right questions. By systematically gathering all that info, the fever's traits, the company it keeps with other symptoms, the patient's context, their environment, clinicians can significantly narrow down that list of possibilities. It's really a testament to the value of critical thinking, of meticulous inquiry in putting together these interwoven clues, helping us solve the body's puzzles. And, this journey of understanding our body's signals is fascinating. It's endless, really. Think about it. If just one fever pattern, like those malaria timings, can point so precisely towards a diagnosis, imagine the power when you combine that with, say, a specific type of rash, that non-blanching petechule one we talked about, or a unique cluster of muscle and joint pains, or that telltale travel history. How much more can our bodies reveal when we really learn to listen and learn to ask the right questions? So keep learning, keep being curious, keep asking those insightful questions. Your body is communicating all the time.